Welcome to the EKG Guy. If this is your first time, I'm glad you could join us with this week's EKG of the week. And here we have a 72-year-old male with sinus node dysfunction presenting with this EKG. So what I'd like to do is go through these here things on the right, okay? Try to address each one of these issues or aspects of the EKG, and then make a final interpretation. Once you're finished, restart the video and we'll go through it together. Alright, so hopefully you get a chance to go through the EKG yourself. And now let's walk through each aspect of it here so we're not missing anything. And this is the approach we've been using and we'll continue to use unless we find something else that works a little better. But first thing we want to do is look at the regularity of the rhythm, okay? And in this case, we want the regularities, meaning the distance or time between intervals, to be consistent for it to be regular, okay? If it's not, then we would call that an irregular rhythm, and then from there we'd have to find out if there is any regularity to that irregularity, okay? In which case it would be a regularly irregular rhythm, and or if it was always irregular, such as an atrial fibrillation, which is an irregularly irregular rhythm. Okay, so let's look here to see what we mean. So what we look here, and we want to use these rhythm strips down here. This is a standard 12-lead EKG, and these bottom leads here are 3 rhythm strips, okay? And what we want to look for are intervals being consistent throughout. We typically look for these R waves here, okay? These are these positive deflections here, okay? And these R waves, you can see that there's about 6 there. From one R wave to the next, we call that an R to R interval. And as you can see, here's the next R to R interval, and then one that follows, and so forth. And these are all different R to R intervals. If they're the same throughout, we call that a regular rhythm. And in this case, the distance between them is quite regular. So this is in fact a regular rhythm. Okay, so that's the regularity. Next we look at the rate, and we look at the regularity first because then it dictates some ways that we can find the rate. Okay, with irregular rhythms, we're more limited in the ways that we can find it. But now that we have a regular rhythm, what we can do is, knowing that from beginning to end is 10 seconds, if you multiply that by 6, that's 60 seconds, or 1 minute. We can then count the complexes, multiply by 6, and get an estimate of the rate in beats per minute. Okay, so what we can do this with either the atrial rate by using the P waves or the ventricular rate by using the QRS or T waves. So in this case, we can do that here by saying 1, 2, 3, 4, 5, 6, okay, meaning that there's 6 QRS complexes there, so the estimate rate should be about 36 beats per minute. So we got 36 beats per minute, okay. Another way that you can do this, because we're dealing with a regular rhythm, is by finding an R wave or one of the complexes that falls on one of those thick lines. So in this case, we can do this one here. Notice it's on one of the thick lines, and the next one that falls almost halfway between those thick lines of these boxes, okay, and we're going to count the number of these dark lines between it. So 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's about 8.5. So what you would do from that point is then take 300. Okay, this is a number that we won't get into here, but it's pretty much the big box is over 1 minute, and you do 300 divided by the number of thick lines that we found to be as 8.5, okay, between the R waves or within that R to R interval. And if you were to do this, you'd get an estimate of about 35 beats per minute. Okay, it was like 35.2 or 35.3 when I calculated it earlier. So that's an estimate of the rate there, and as you can see, close to our 36. Now the actual rate that the machine gave us here was 34 beats per minute. Okay, so the machine, I'll just put right here. So as you can see, quite close, 34 beats per minute there. All right, let's move on here to the next aspect, and that's the rhythm origin. So where is this rhythm actually originating from in the heart? That's what we're asking here when we talk about the rhythm origin. Okay. Now, one way that we've been doing is by looking at these QRS complexes. If they're wide, that may suggest either aberrancy, okay, some intraventricular conduction delay, or that the rhythm's not originating from, it may be originating from the ventricles. So in this case, we have narrow QRS complexes, okay, so then we look for P waves that are preceding these complexes, okay, and as you can see here throughout, there are not any clear P waves, okay, maybe some fibrillation, but no P waves in lead 2 or V1, which are the best leads that will show it, okay? This you may think is a P wave, but if you look up, there's nothing there. So I would say there are no clear P waves here. So now we're dealing with a rhythm that is narrow, has narrow QRS complexes, okay? And it has no preceding P waves. So if we draw out our heart here, okay? This being our right atrium, right ventricle, and left ventricle. Our atria up here that produce the P wave, and we're saying there's no P wave present, so it's not coming from the atria. And then we have normal QRS complexes, which are from the ventricles, okay, so likely not originating from here, okay, and therefore it must be originating from somewhere between where that AV node or junctional rhythm takes place, okay. So that is likely where this complex is originating from, okay, so we'll call this likely coming from the AV junction. Hopefully that makes sense there, okay. Now let's find the ventricular axis. So let me just erase this here. The ventricular axis, and we're dealing with an adult patient, right, a 72-year-old male. So normal ventricular axis that we use is between -30 and +110 degrees. I mean that this is all normal axis in this adult patient, okay? This is considered over here left axis deviation in this region. This would be right axis deviation, okay? In this region here we would call a northwest axis, because this is north and this is west, so that's where you get that northwest, okay? Or a superior rightward, because this is rightward and up, so superior rightward axis. Or no man's land. So a number of different things that you can call this. So again, we said normalize in this region here. Remember that leads 1 sits here, lead AVF sits here. Okay, that's the positive ends of those leads. So now let's find the axis here. Okay, where does this ventricular axis, so the QRS complexes are what we're looking at because it's ventricular. Okay, so let's look here. We said that lead 1 is here. Lead AVF is here. These are the best leads to look at, especially when you're just starting off with trying to find the axis. There's a number of ways you could find it, and some that are a lot faster, but we will use this one here. Okay, so here's lead 1, and here's lead AVF. Okay, so not many complexes, but here's our QRS complex, and you can see that it's mostly positive. Because of that, we'll go towards the positive end of lead 1, okay, in that direction. If we look at AVF, if you look at this one here, you might say this is mostly negative because that negative portion is more negative. So this is the positive end of AVF. We're going to head away from it, okay? So that puts us in this region here, okay? Somewhere within here, as you can see. And notice that left axis deviation takes up some of this, and so does that normal area. So we have to figure out, are we over here with a left axis shift, or are we over in this region, okay? So how do we do that? Well, what's nice is that we have a lead here called lead 2, okay, that sits at +60 degrees, and actually perpendicular to that lead is a lead that comes this way here, and that comes at -30 degrees, as you can see, just like this one, okay? And what that means is if lead 2 is positive, we'll go towards the positive end of lead 2. If it's negative, it'll go away from it. So negative would put us in this region, and positive would put us over here. So if we look at lead 2, which is this one here, you can see that this complex here is mostly positive. Okay, you can see that. So because it's mostly positive, we're in this region here, which means we have a normal ventricular axis. Okay, so this is a normal ventricular axis, and the machine actually gave us -17 degrees. Okay, so where does -17 degrees sit? Well, if we erase this here, okay, here's that -30 degrees. Negative 17 would be about right here, where we were expecting it. Okay, so hopefully that makes sense. So this is a normal ventricular axis in this adult patient. Next, we have atrial conduction. Okay, this is where I'd like to focus on, are there any atrial enlargement abnormalities within the atria? Okay, either the right or left atria. And here, we don't have any P waves that we made out. Okay, now P waves may be buried within the QRS complex, which may be the case here. So in this case, we can't comment on that, okay? Because when we look at atrial enlargement, those specificities that were laid out have to do with making sure that the sinus rhythm is present, okay? And if we're saying that the rhythm's not originating from the sinus node, then we actually can't comment on right or left atrial enlargement, okay? So that's one thing to keep in mind. All right, so again, what we're looking at here are these complexes. Here's a normal complex. This is our P wave, QRS complex, and T wave. Okay, here's our P wave that we said was not present, so we said nothing to comment on atrial conduction. Next, we look at AV conduction, which is atrioventricular. Remember, that's from our PR interval, which is from the beginning of our P wave to the beginning of our QRS complex. That's our PR interval. And because we said that there's no P wave present, we can't comment on that here. Okay, if it's buried in the QRS complex, you may see a short PR interval, but in this case, we won't mention that. So nothing to comment here on AV conduction. Just a side note, remember that the PR segment is from here to here. Okay, so meaning that the PR interval equals the P wave plus the PR segment. Okay. Next, let's look at IV conduction or intraventricular conduction. With intraventricular conduction, we're looking pretty much at the width of the QRS complexes. And we pretty much mentioned earlier that they seemed narrow. And what do we mean by that? So from the beginning to the end of our QRS complex, that's the width we're looking for. Normal is between 70 and 110 milliseconds, okay? And some are saying 120. Here at Mayo Clinic, we use 70 to 110. Once you hit 120 or 3 small boxes, we consider that prolonged, okay? So we're going to be sticking to that criteria we use here. Okay, so the QRS complex in this case was actually normal at 96 milliseconds, okay? So normal IV conduction, the QRS interval was 96 milliseconds, which is within that normal limit. Okay, next we want to look at the waveforms, and that's that next portion there. Okay, so let's start looking at that. We'll just erase some of this here, okay, and then we'll move on to that. Okay, so hopefully this is making sense. Again, we're finding a lot of different things, and as you can see that really going through an EKG, you have to have some sort of systematic approach, or you'll, more often than not miss something, okay? And we don't want to miss anything that's crucial, okay, especially when it affects patient care. And that's why you can see we always do this systematic approach as we move through the EKG, okay? So now let's move on, we said, to these waveforms. So first we want to look at the PR segment. So remember, if we just draw this out, here's our P wave, our QRS complex, that represents actually an RS complex, and this is our T wave. The PR segment is we're looking from here to here. We're asking ourselves, is it elevated or is it depressed? Okay, and because we said that there's no P wave, we don't really have much commenting on the PR segment. Next, we want to look at the QRS complex, which is this one here, and we're looking for any abnormal or pathologic or significant Q waves that may represent a prior infarct, and sometimes an ongoing one, okay, so, or acute injury. So what we see here actually are a Q wave actually in V1, okay, in V2, and maybe V3, you may see this initial portion that may be a small R wave, but certainly in V1 for sure, we see that, okay? So V1 is one that we should keep on. So I'm just going to comment on that. Plus or minus V2 to V3, okay? It's hard to always get that, but V1 for sure, and you can see it down here too in lead V1, okay, in each lead. So all of these are deep Q waves that are not normal, okay? And you can kind of almost see, we'll get to the loss of R wave progression throughout the precordial leads shortly, but something to keep in mind there. All right, next we're looking at the ST segments, okay? So ST segment is this portion here from the end of our QRS complex up to the beginning of our T wave. Is there any elevation or depression, we're asking ourselves, okay? In this case here, okay, there's not much ST segment elevation or depression, okay? Not something that I would certainly comment on. You see a little issue here at the end in the complexes, but nothing significant, and that isn't depression or elevation that's going on there. So really not much to comment on here that would be significant or stand out, at least that would change our management. Next we look at the QTC interval, and what do I mean by that? That is from the beginning of our QRS complex all the way to the end of our T wave. This is the QT interval. You'll notice there's a C there, and C stands for corrected, and that corrects for heart rate, okay? Most of the machines use the Bazet formula, which accounts for heart rate. There's many other formulas, but in this case, this male patient here, okay, normal should be less than 440 milliseconds. In this patient here, it was 439 milliseconds, okay? So again, within normal limits for this male, all right? Now normally not until around 500 milliseconds do we get a little concerned so much, and sometimes the machine will give us an alert, whether if we're in the hospital of a patient that is having a more prolonged QTC interval, because this is could put patients at risk for torsades, okay? Which is could be a life-threatening arrhythmia, okay, or ventricular arrhythmias. All right, so let's move on to the last few things. And these last two things, first of all, is there anything else that we're missing here? Okay, I think those are about the main things here. Some other things we should note are the R wave progression, okay, and these have to do with the precordial leads, these last two things, the R wave progression and the transitional zone. So let's look at R wave progression. And what you want to see with R wave progression is a slow increase. If I can draw this up, it's not going to be the best, so let's try it again. Yeah, so this is going to be hard, but anyways, you want to see a steady increase in the R wave as you go across the precordial leads, okay, and actually a decrease in the S waves. So these are the S waves here, okay. They should actually go down. Obviously the drawing is not going to be fit, and I'm not going to waste your time trying to master something that will take me forever to do. So the R wave should increase as we go from V1 to V5, okay. So from V1, which is this one here, V2, V3, V4, V5, the R waves, which are absent here, maybe slight one there, slightly there, but then you can start to see them more here and here, okay? But they're pretty much absent in V2 to V3, okay? Because we don't really see those in those leads, we would call that a poor R wave progression. All right, so hopefully that makes sense. And that can signify an anteroseptal infarct or something when you have those poor anterior forces that may be going on there. Okay, so we will get to that shortly. Next is the transitional zone, and this is where you're going from mostly negative complexes to mostly positive complexes, the QRS complexes, in the precordial leads. So you'll notice here that these are mostly negative, mostly negative, mostly negative, still mostly negative, and maybe here you start to get almost an isoelectric or maybe slightly positive. So the transitional zone here is right around V5, I would say, but normal is between V3 and V4. So between V3 and V4, you should see that change from being mostly negative to mostly positive, but we don't see it. We see it occurring later, and because of that, we call that a late transition, okay? Or we call that a clockwise rotation. Okay, so clockwise rotation because it's occurring later. Both mean the same thing. All right, and those can both suggest that we have poor anterior forces, and most of it's coming from the left side. So let's review what we have here. We have a regular rhythm, a rate around 36 beats per minute, okay, so slower, at the AV junction, likely origin, and that should tell you that we're dealing with junctional bradycardia. Okay, so, and we'll get to this shortly, but this is junctional bradycardia as our underlying rhythm. Okay, the axis we said was in the normal limits. Okay, slightly left or shift, but physiologically normal in this adult patient. Atrial conduction is, we don't have anything to say, or AV conduction because we couldn't see any P waves there. IV conduction was normal, that in the intraventricular space. There was nothing on the PR segment or ST segment, but we did say these Q waves. Okay, and this likely suggests this poor R wave progression that we mentioned here, that late transition, those Q waves in these leads, okay, showing a really low forces in the anteroseptal region, likely suggesting a prior anteroseptal infarct. Okay, and this is actually what the patient had. Okay, and we'll call this an old anteroseptal MI. We don't see any ST segment changes that would suggest it's more acute, and the T waves have kind of reverted back to normal. So hopefully that makes sense there. So an old anteroseptal infarct. Now we always want to compare to a prior EKG, and one thing to note on the prior one, it did show the anteroseptal MI, and it actually showed a junctional rhythm. So junctional rhythm on the other one, and it also showed the anteroseptal MI, which was likely suggesting an old one. Okay, so these are the new interpretation, these are the prior one. So I want to just go over a few things. Notice that we said junctional bradycardia here, junctional rhythm here. And what you need to know is that there's an intrinsic rate within different regions of the heart. So if we draw out our box diagram here, this being our right atrium, right ventricle, and left ventricle, we have our sinus node up here, has these internodal pathways in a Bachman bundle, comes to our AV node. We have our His bundle, splits into the right bundle branch, left bundle branch with the left anterior and posterior fascicle, and something like this. And what you want to note is that different regions, okay, and we'll kind of say that the atria have their own intrinsic rate, which includes the sinus node. So we'll say that the atria has a intrinsic rate between 60 and 100 beats per minute. Okay, so pretty much the sinus node and all this atria. This junctional, AV junctional region has a intrinsic rate between 40 and 60. Okay, and these are all estimates. There's more exact ones, but this is a good way to and framework to keep in mind. And the ventricles have their own. The ventricles between 20 and 40 beats per minute. Okay, and this can sometimes help you to locate where that rhythm is originating from. So because in this case there was a regular rhythm, a rate that was slow with no P waves, we had an idea that this was coming likely from a junctional region, meaning that it would come from somewhere in this region. So let's see if we can erase some of this here. So because it's coming from somewhere in that region, you can sometimes see not only the QRS complexes that result as it heads downward, but also the retrograde. You may see inverted P waves as it goes away from those leads, in which case these inferior leads you may see upright P waves, okay, as it's going, or negative P waves, excuse me, as it moves away from the inferior leads down here. That's lead 3. Anyways, the main thing I want to talk to you about is the terminology of these junctional rhythms. So notice we said the atria and the sinus node have a rate in adults, okay, between 60 and 100 beats per minute. And then the AV junction, we're saying is between 40 and 60, and the ventricles 20 to 40. Let's focus on this one here, okay, because we said this is a junctional rhythm, and what the junctional rhythm means is that it has a rate between 40 and 60 beats per minute. Okay, when it's a bradycardia, it means it's less than that 40 beats per minute, and that's why we call this. So this is junctional bradycardia when you have a rhythm originating from the AV junction that's less than 40 beats per minute. Now, if the rate were between 60 and 100 beats per minute, this would equal a junctional actually an accelerated junctional rhythm. Okay, so pretty much an accelerated junctional rhythm between 60 and 100. Now, if it was over 100 beats per minute, just like any other, we call that a junctional tachycardia. Okay, so just like this one in atrial, over 100 is a tachycardic rate or fast rate over 100. Same thing with these junctional rhythms. So a junctional rhythm less than 40 beats per minute, that's why we have this junctional bradycardia. A junctional rhythm has that intrinsic rate between 40 and 60 beats per minute. When it goes between 60 and 100 beats per minute, we call that an accelerated junctional rhythm. And then when it goes over 100 beats per minute, we have junctional tachycardia. Okay, so it's just some nomenclature that is sometimes confusing and sometimes worth reviewing. All right. Well, that's all we got for this week. So we have a junctional bradycardia and an old anteroseptal MI that was there from prior. Okay. I hope you learned something, and I look forward to seeing you next week. All right. Have a wonderful week. Now, I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then go to put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access, okay? And access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there, share with your friends if you find this helpful, and please leave a comment if there's any topic, or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.